Hello, my name is Dr. Louis Mazzarelli. I'm the Director of Molecular Imaging at Lawrence Memorial and Westerly Hospitals, part of the Yale New Haven Health System. This is our prostate-specific membrane antigen case series. This is case 1 with our title, Small Volume, Single Lesion, Single Organ Metastatic Disease. So what are the objectives of this case series? They're as follows. To demonstrate the clinical impact of detecting and characterizing solitary or rare metastases with PSMA PET. Up to 20 to 30% of patients present with oligometastatic disease, and accurate detection impacts curative versus systemic therapy. PSMA PET can detect small, atypical solitary lesions earlier than CT or bone scan. Teaching point here is that one lesion could be a turning point in care decisions. So let's look at our first case. It's a case for a biochemical recurrence. 69-year-old with prior prostatectomy, a rising PSA, and a current PSA of 0.69 nanograms per cc. The Gleason at presentation was 4 plus 3. So it was grade group 3 carcinoma at diagnosis. So as we said in our teaching point, we begin with the MIP, the rotating MIP, and we look for an area of uptake that is clearly greater than background. We look for physiologic uptake, and here we clearly see it within the lacrimal glands and the kidneys, moderate uptake within the liver and spleen, and very low uptake within the bowel, and very little uptake within the marrow or the blood pool. Notice also the absence of significant uptake within the urinary bladder. But what we do see is a clear focus of abnormal radiotracer uptake within the left pelvis. So this is our only focus of uptake in this patient. We see this on a static coronal image where we see an area of uptake as we identified on the MIP within the left pelvis. And then similarly, I'm just pointing out the absence of uptake within a large renal cyst. So it's important not only to see things that are accumulating radiotracer, but similarly that have no radiotracer. So let's look at this a little bit more carefully. Let's talk about solitary nodal metastases. PSMA PET can reveal single subcentimeter nodal lesions that are occult on CT or MRI. Most common sites are in the obturator, internal, and external iliac chains, but more commonly noted also in the presacral chains and occasionally in the periaortic chains. Understand that treatment with prostatectomy or radiation therapy may disrupt the normal drainage pathways, and therefore we may see skippage of nodal stations. It's important to assess presacral and mesorectal regions, and the detection of a solitary node can alter management, and that can lead to a change, salvage radiotherapy, surgical dissection, or systemic therapy escalation. And this is important both in the initial staging and the biochemical recurrence spaces. So in terms of our interpretation approach, start with the MIP, confirm on the axial images, correlate that abnormality with CT morphology, and understand that you want to look at the morphology of that area of increase on the CT images, whether that node is ovoid or irregularly shaped, how large that node is, understand whether or not there's a fat plane preserved, or if there's a fatty hilum that's been preserved. Recognize pitfalls. Do not disguise, do not miscall lymph nodes with sympathetic chain ganglia, small vessels, or inflammatory nodes, and always interpret within clinical context, understanding what the PSA kinetics are, the prior therapies. As teaching point, one PSMA-avid node may change the treatment plan from systemic to potentially curative salvage radiotherapy. Let's talk a little bit about lesion measurement on PSMA with respect to CT. Understand that on PSMA PET, uptake often appears larger than anatomic size due to partial volume effect and spillover. Avid lesions may show a halo of uptake around the core, and that's not a true tumor measurement because SUV intensity is more informative than size for reporting. So how do you measure on PSMA PET? You report the location and the intensity, but not just the size. When the measurement is necessary, please use the axial fused PET CT scan to look back at the lymph node on the CT component. Measure the core avid lesion and not the peripheral halo, and correlate that with the MRI or CT for anatomic dimensions. So just as an example, and this is really important related to appropriate windowing. So if we initially were to measure this lesion, looking at the halo and looking at the entirety without appropriate windowing, we see that the measurement of the lesion is 2.3 centimeters by 1.9 centimeters. When we appropriate window, we over window, we actually correlate beautifully with the CT, which is now showing us the node is 1.4 centimeters. So it's important to really go back to that CT to have an accurate measurement of the lesion. Let's talk a little bit about physiologic uptake that can occur in lymph nodes, and that can be commonly seen in the hilar, inguinal, and axillary lymph node regions. The uptake is generally low level, it's symmetric, and clearly lower than abnormal uptake. Comparatively, understand that a single lymph node in the left supraclavian region in a patient with large volume disease may be representative of Virchow's node, which is a classic pathologic node that may be seen in high volume disease. When we talk about interrogation of abnormal lymph nodes, as I mentioned on the previous slide, we want to look at imaging clues. Are those nodes morphologically abnormal? Are they round or oval? And clearly, we want to be able to discriminate uptake within the node from background. So intense focal uptake is a marker for disease. Correlate that node and its appearance with the appearance on CT or MRI, and then understand that these nodes must differentiate from background uptake. So let's take a look at this again. We're seeing a coronal MIP image, a static image, and then we also see the fused image. And here we see that single intense radiotracer uptake with that node clearly greater than background uptake. But comparatively, you can see the low level uptake within the high level lymph nodes. In this case, you can see the symmetry, you can see the relative low level uptake, and then beautifully visualized again on the high region on the coronal fused image, we see that those lymph nodes are very low level. So those are benign. So let's look at another case. This is a metastatic disease evaluation. This is a 64-year-old with a history of prostate carcinoma in 2010, prostatectomy at that time, and the diagnosis was a Gleason 7, 3+4, extracapsular extension was present. The patient had biochemical recurrence in 2012 and underwent salvage radiotherapy. PSA surveillance demonstrated a slow doubling time. PSA in 2016 was 0.22, 2019 0.9, and 1.71 in November of 2020. I'm just showing you as a comparative CT scan of the pelvis in May of 2018, a subtle small lymph node in the left iliac chain. And this patient then went on to have a fluciclovine PET in 2020. PSA at that time was 1.7. And in that 2020 study, we see that there's a focal area of increased radiotracer uptake with that left pelvic lymph node, slightly greater than marrow and greater than other lymph nodes, and suspicious for neoplastic disease. Continued surveillance here occurred, and in 2021, the patient presented for another PSMA PET. Let's look both at the MIP image and at the axial fused image. And as we see, the axial fused image demonstrates a focus of clearly increased radiotracer uptake in this left iliac node, significantly greater than background. And the PET scan confirms that the only site of recurrent disease is in this solitary lymph node in the left iliac chain, no other lymph node. As we saw before, these are physiologic lymph nodes within higher lymph nodes and no other additional lymph node anywhere else or any other disease otherwise. So this was a case of monometastatic nodal disease, and at this point, the plan was XRT to the nodal chains with a boost to the lesion. So this is clearly a change in the patient's plan based on single monometastatic lymph node disease. Let's move to another case. Solitary bone lesion. 78-year-old with a history of BPH and transurethral resection of the prostate. Elevated PSA in 9.4. NPMRI demonstrated a PIRADS 5. On biopsy, this was a Gleason 4+3, grade group 4. Let's take a look at this case. MIP images demonstrate an abnormal focus of uptake correlating with the sampled PIRAD 5 lesion. That was a Gleason 4+3, and that was in the right prostate, correlating with the peripheral zone. But again, we have to look very closely at this MIP. We recognize those patterns of physiological uptake, but we similarly see an area of abnormal uptake within a left rib. That's our only focus of uptake beyond the prostate, and therefore we need to interrogate that more closely. Let's look at the coronal fused image, and here we see that same focus of abnormal uptake within a left rib. And this is indeterminate. But let's do a better job of being able to distinguish whether this is monometastatic osseous disease or something else. So looking at the axial images on the CT, we see that same focus of metabolic uptake, that same focus of PSMA uptake within that left-sided rib. And we then correlate that with the axial image. And clearly on the axial image, this lesion has a peripheral rim of hazy sclerotic density and a central lucent lesion. So this is low-level uptake, clearly less than primary lesion. It has a well-defined sclerotic rim, central lucency, and very importantly, we go back and we look at the patient's previous imaging. And here, this is a reference CT from 2018 and demonstrates that same lesion. So that long-term stability in conjunction with the appearance on CT, that low-level uptake on PSMA allows us to make the appropriate diagnosis of fibrous dysplasia. It is critically important that when we find a solitary bone lesion in a patient with disease nowhere else beyond the prostate, that we do an incredibly great job of looking back at all preceding imaging so that we can give this patient a benign diagnosis of fibrous dysplasia rather than of single monometastatic osseous disease. So let's talk about benign mimics. Fibrous dysplasia is a fibroosseous process that can show PSMA uptake, and that PSMA uptake may be variable. That uptake could mimic metastatic prostate carcinoma, especially when it's focal and intense. Typical sites of disease include the ribs, the pelvis, long bones, and the craniofacial skeleton. The imaging clues, okay, are that on CT or MRI, the lesion is oftentimes ground glass centrally and has well-defined sclerotic margins and has no aggressive periosteal reaction or soft tissue mass. PSMA uptake may be present, but it's often discordant with benign morphology. So it's very important to go back and correlate with previous cross-sectional imaging so we don't overcall a solitary metastasis. There are other foci of benign mimics that we need to be aware of. Things like healing fractures, Paget's disease, and degenerative uptake. This is a great example of Paget's disease. So we have a whole body bone scan that was performed at the time of patient diagnosis, and there's a solitary focus of intense radiotracer uptake within the calvarium. But at the time of PET scan, we can see that there's only very low level uptake within the skeleton in a patient who had correlative anatomic imaging of Paget's disease. So as a teaching point, always correlate the PET uptake with CT bone morphology. And we want to importantly, not all avid bone lesions are metastases. Let's move to our next case. A 57-year-old with rising PSA, 4.32, abnormal NP-MRI, PIRADS 4, biopsy at the time, Gleason 4+3, and this is an unfavorable intermediate risk prostate cancer. We show you images from this gentleman's prostate MRI, T2 hypointense lesion, well circumscribed but small, DCE demonstrating intense early enhancement, and correlative abnormal diffusion-weighted imaging that's very bright and dark on ADC, but this is an EADC, so we inverted, so it's correlative with the DWI. So this is this patient's prostate carcinoma at the time of diagnosis. Let's look at this patient's MIT. The only focus of disease is a subtle one, but we see it clearly within the prostate correlating with this patient's disease. This is the time of diagnosis. And here it is on the axial images, with the fused image. We see the focus of intense radiotracer uptake within the right peripheral zone, and this correlates beautifully with the MRI appearance. So let's look at this patient's coronal MIP image. Again, we see the focus of abnormal uptake within the right peripheral zone correlating the patient's sampled neoplasm. But if we look closely, we see that there's paired low-level uptake within the upper thorax, left slightly greater than right. So let's interrogate the fused image more closely. Axial and coronal images, and we see that there's paired uptake within the upper cervical region, left greater than right, left greater than right. This is not disease. These are cervical ganglia. Locations of cervical ganglia may be within the cervical region, mesentery, the mediastinum, the pelvis. The imaging clues of cervical ganglia or other ganglia, they're elongated and linear shape. They're symmetric and bilateral. They may have mild to moderate intensity. And clearly, they're in areas that are different where we expect nodal disease. They don't have the same correlate of nodal enlargement. So be aware when you're looking at PET-CT with PSMA that you may see ganglia. Same case. This patient is now status post-prostatectomy in March of 2025. Rising PSA, 0.35 in June of 2025. Currently 0.9 in August of 2025. Let's look at this patient's rotating MIP. Patient's status post-prostatectomy, radiotracer uptake within the urinary bladder, but no uptake at the prostate bed. But if we look very carefully, we see that there's a solitary focus of uptake posteriorly on the MIP. Lower level uptake in the liver and spleen, physiologic uptake otherwise within the salivary tissues, as well as within the genetic urinary system. We look very carefully for that focus of uptake on the axial fused image. We see that there's a focus of intense radiotracer uptake within the left sacrum. And that same focus of uptake is identified in the left sacrum on the coronal fused images. And again, here's a blow up of the axial images. Importantly, we go back and look at the staging PET-CT scan that was performed several months earlier, and this focus was not there. This is a case of single monometastatic osseous disease in a patient who precedently had unfavorable risk intermediate prostate cancer. Let's move to our next case. 57-year-old with a history of prostatectomy, pelvic lymph node dissection. In September of 2019, a high PSA of 120, Gleason grade group 5. At the time of diagnosis, Gleason 4+5, EPE, negative lymph nodes, climbing PSA, and abnormal PSMA in August of 2024, which we show here, show two intense foci of uptake, one within the pulmonary parenchyma and a significant focus of abnormal uptake within the right paratracheal region. The patient is restaged May of 2025 and demonstrates interval response to therapy of the right paratracheal lymph node and to a lesser extent of the pulmonary uptake. But let's take a look at the follow-up PET-CT scan. Unfortunately, this patient has two new foci of uptake within the intracranial space. And let's take a look at that rotating MIP. Again, we see those two foci of uptake, and clearly we can see them as being distinguished from the calvarium on the axial fused images. So these are evidence of PSMA-avid intracranial metastatic disease. Lesion 1 and lesion 2, clearly not in the calvarium, but within the cerebellum. Let's talk a little bit about oligometastatic brain disease. Brain metastases from prostate cancer are rare, less than 1 to 2% of metastatic cases, and usually occur in late stage. Typically occur in patients with advanced castrate-resistant disease or widespread metastases. Lesions are often detected first on MRI, but PSMA PET may demonstrate avidity in concordant locations. Histologies are often associated with small cell neuroendocrine variants and adenocarcinoma, so the small cell variants are more common. In terms of interpretation, MRI remains the gold standard for cranial evaluation, but PSMA PET findings should be correlated with MRI. And in this case, we see those same lesions here that we identified on PSMA PET, the more inferior and the more superior lesions on both FLAIR, T2, and dynamic contrast imaging. Understand that PSMA uptake can also occur in some benign entities like meningiomas or vascular malformations or inflammatory processes. So it's very critical to then correlate with the MRI findings. So the clinical value here is a PSMA-avid brain lesion in the right clinical context may clearly upstage disease and alter management, stereotactic radiotherapy, neurosurgery, or systemic therapy change. So let's go over our conclusions. One lesion can change everything. A single focus may upstage disease and alter management strategy. The PSMA PET has many strengths, including the detection of subcentimeter nodal, bone, or visceral lesions that may be missed by CT or MRI. And it has really important clinical integrations. Solitary nodal disease may make a patient a candidate for salvage RT. A solitary bone lesion goes to MDT or multidisciplinary tumor board with stereotactic RT as a potential treatment plan, or systemic intensification. Solitary organ metastases, including those in the brain or liver, require multidisciplinary input. Always confirm the findings on PSMA PET with CT and MRI. Avoid false positives from physiologic uptake or benign mimics. Understand that solitary disease may reflect lower biology, but it also can reflect intra and intratumoral heterogeneity, and these solitary metastases can occur in unusual places like the brain. Thank you for your attention. I invite you all to join me in case series 2 as part of our PSMA case series.